So good morning, everyone. So we had a new grant rounds today. So we had an international speaker. So for today, we had the pleasure to have Dr. Coutinho. Dr. Coutinho is a stroke neurologist from the Amsterdam University Medical Center. This is from the Netherlands. He has training also. He obtained a PhD in 2014 from the University of Amsterdam. And he completed a postdoctoral research fellowship at the University of Toronto from 2014 to 2015. He's a staff neurologist at the Amsterdam UNC, and he combines his clinical work with research. His research actually focused in the diagnosis and treatment of the acute ischemic stroke, the cerebral venous thrombosis, and he's a very accomplished researcher with more than 130 publications. He lives in Amsterdam. He has like his wife, 2 kids, and we're very happy to have Dr. Coutinho to be in the grand rounds. So welcome, Dr. Coutinho. You had all this spotlight with you.
Thank you so much, Sergio, for that nice introduction. Yeah, so I'm going to talk about one of my specialties. Like Sergio said, I focus on diagnosis and treatment of acute ischemic stroke. But I've also had an interest in cerebral venous thrombosis for over years, and it was actually the topic of my PhD. And as all of you know, it's a much rarer disease, so there's less scientific news that is coming out. So it's easier to keep that as an interesting side specialty. So I've prepared quite a few slides because I understood that we have around 50 minutes for the presentation and then some room for questions. But if it's taking too long, I may skip a couple of things, but let's see how far we can get. So these are my disclosures. So what I aim to talk about, I want to discuss a little bit about background on CVT, because I'm not sure how much all of you know about this condition. So I'm just going to give a bit of overview that may be a bit redundant for some of you. And then I want to discuss a couple of treatments because I think that's where most of the news is coming from over the past couple of years. I want to talk about anticoagulation in the acute phase, endovascular treatment, and anticoagulation in the chronic phase. And then for the last part, I want to discuss VITT, vaccine-induced immune thrombotic thrombocytopenia, which is a disease, as many of you may know, is related to the COVID-19 vaccinations, and which popped up about a year ago, in which my group has been researching ever since then. So, as probably a lot of you will know, cerebral venous thrombosis is what we say. It's a disease of the young with an incidence of around 12 to 15 per million per year, which is of course rare, but it's actually increasing. So a lot of studies have looked at this over the past a couple of years, and they all show that the incidence is going higher and higher. And this has probably to do with improved diagnostic modalities, which allows us to diagnose this disease more readily. You can see here in this graph that it's really a disease of the young. I've depicted here the relative incidences, so not the absolute, but the relative incidences of CVT in blue and arterial stroke in purple. And you can see that the majority of patients, around 2/3, are between the ages of 16 and 44, while of course for arterial ischemic stroke, the majority of patients are very old. The median age is 37. And another epidemiological interesting fact about CVT is that, at least among adults, there's a highly skewed sex ratio, which is due to what we call sex-specific risk factors, and three out of 4 patients are women. So here are some of those risk factors. We wrote a paper on this a couple of years back, so if you want to read more, you can pull out the paper. But there's many risk factors that have been associated with CVT. Like I said, we have the sex-specific risk factors, especially oral contraceptives, but definitely also pregnancy and puerperium. Actually, it's mostly the puerperium that appears to be the risk factor, not so much the pregnancy, especially in the first 6 weeks after delivery. There's a definite increased risk of CVT. The hereditary thrombophilia, similar to what we know of deep vein thrombosis of the leg and pulmonary embolism, is a risk factor. And then we have all those systemic diseases like cancer and rare diseases like VITT disease, which is mostly around the Mediterranean. Antiphospholipid syndrome is definitely quite a major cause of CVT, so it's definitely something to look for in a patient with CVT for which there's no obvious explanation. And then there's other facts like, for instance, obesity, which for some reason is here listed under iatrogenic, which is of course not correct, but obesity is definitely a risk factor, especially in combination with oral contraceptive use. So it's always helpful to know a little bit about the anatomy of the cerebral venous system. And I generally teach the residents that you can divide it, the cerebral venous system, into a superficial venous system, which is color-coded here as the cortex and the first 1 centimeter of subcortical white matter. And this is from a paper by Leach and others already around 20 years ago, but it's a very good paper, so you can read up on it. And most of the superficial venous system is drained by the superior sagittal sinus, as you can see here. And you have all these cortical veins that drain into that sinus. And from there, it goes to the transverse, the sigmoid sinus, and then the jugular vein. And the rest is then, of course, drained by the deep venous system, as you can see here, which is the deeper white matter, the basal ganglia, and the thalami. And this mostly goes through the deep veins, like the internal cerebral veins and the vein of Galen. And then they come together within the straight sinus, and then within the confluence, they also go into the transverse sinus, sigmoid sinus, and then back to the heart through the jugular vein. So the clinical manifestations of CVT are quite diverse. These data come from the ICVT study, which is already quite an old study, but it's still a very good study to derive your clinical data and your outcome data from. And you can see that the majority of patients have a headache, around 90%. So not all of them. There are some patients that do not have a headache, but it's very rare. And those are mostly patients with who are already admitted, who are already on treatment for other pains, for instance, so they probably don't suffer pain as much, or they have an isolated cortical vein thrombosis, which generally does not give intracranial hypertension, so they have less headache. Focal deficits like paresis, aphasia occur in various degrees, and what is very typical of CVT is that a lot of these patients have seizures in the acute phase, around 40%. So that's, of course, much, much higher than what we see in ischemic stroke or even in intracerebral hemorrhage. And if you look at the patients who actually have parenchymal lesions, which not all patients have, but if you look in that group, the proportion of patients that have seizures is much higher. It's around 2/3. So if you want to diagnose CVT, nowadays we use either one of these two techniques. So you can use MRI with MR phenography, as you can see here, or you can use CT phenography. I guess it depends on what your hospital uses most, if it's more MRI or CT based. Both are fine to diagnose CVT, although of course MRI is superior to look at the brain parenchyma. In my experience, CT phenography is actually a little better to diagnose CVT, especially if your hospital uses time of flight MRV and not contrast enhanced, which a lot of hospitals use time of flight. Because if you use time of flight, there's a risk of overdiagnosis, because sometimes you don't get a good flow signal in the transverse sinus, but it doesn't always indicate a real thrombosis. So if you use MRI, what you're looking for is a change signal on the T1 or the 2T2 sequences. As you can see here, there's an increased signal here in the superior sagittal sinus, which is abnormal, in combination with absent flow on the MR phenography. So again, if you use MRI, it's fine, but be aware if you use time of flight MR phenography, you sometimes tend to overdiagnose CVT because you get false positive signals. So brain parenchymal lesions, as I said, are not present in all patients, but intracerebral hemorrhage and cerebral edema occur both in around 30 to 40% of patients. And very often they occur at the same time in the same lesion. So you can see here, this is a typical lesion, what we call a venous hemorrhagic infarct, with an area of edema, as you can see here. And within that area, there are patches of hemorrhage here and here. And that's very typical of a venous hemorrhagic infarct. It also generally does not keep to the normal arterial territories, as we know. So that's a way of recognizing it. So the prognosis of CVT, and just to remind everyone, this is not the CVT that we're talking about later when we talk about the VITT, the COVID-19 vaccine-related CVT. So the general CVT, you can see here that prognosis has improved over the years considerably. If you look at the mortality from the 60s, where it was around 40 to 50% in most series, to around, well, this was a decade ago, but I don't think it's changed much. You can see that there's a clear decline, and nowadays mortality is between 5 and 15%. So it's still substantial for a disease that mostly affects young people, but it's certainly going down a lot. On the other side is that if in these surviving patients, they often have what we call long-term sequelae, like epilepsy or decreased vision, but even more often they have things like headache, depression, and difficulty concentrating. And quite a large proportion of these patients are not able to go back to work at least full time. So it generally has long-lasting effects, this disease, even though when you see them after discharge, they often, at first glance, they appear to have recovered quite well, but these long-term sequelae are quite influential on their quality of life. So depending on how you're looking at it, you can see that the prognosis of CVT, either the glass is half full or the glass is half empty, depending on, I guess, the way you want to look at it. Okay, so we're going to talk about treatment of CVT. And again, this is not applicable to VITT. I'll get to VITT later. If you talk about treatment of CVT in general, you can treat the thrombosis, of course, with anticoagulation or with endovascular treatment. And we're going to talk about both. If there's mass effect, you should definitely do a decompressive hemicraniectomy. That's a small proportion of patients. I'm not going to discuss it any further because of lack of time. But if you have a patient with a large hemispheric lesion and clinical signs of impending herniation and radiological signs, you should definitely do decompressive surgery because it's often life-saving. And in the end, a lot of these patients will have a pretty good outcome, especially a lot better than after a malignant MCA infarction. There's a new study that we're rounding up. It's an international study on decompressive surgery, a registry called the Decompress 2 study, which should be published in probably, I guess, 6 months. That also confirms previous studies that the outcome is generally favorable, although not as good as previous studies show, but still definitely worth it. So again, if you have a patient with clinical and radiological signs of impending herniation, you should definitely do decompressive surgery. If there's increased intracranial pressure, and there generally is, in the acute phase, we often only treat with analgesics. I rarely use acetazolamide in the acute phase, although I do use it in the chronic phase, but in the acute phase, I don't find it very helpful. Shunting procedures, we only do in rare situations. So if a patient has a decreased vision or a threatened vision, then definitely you should consider a shunting procedure to save their vision. And of course, patients with seizures always receive anti-epileptic drugs. So anticoagulation now seems very normal for us to use in these patients, but for a long time, it was quite a dilemma because obviously the pro is that it would stop thrombosis and prevent pulmonary embolism, which was not an uncommon cause of death in these patients 50 years ago. But of course, the big fear of using anticoagulation are those hemorrhagic venous infarcts that I previously showed them, because we already know, like I said, 30 to 40% of these patients, when they come in, already have an intracerebral hemorrhage before we even give them anticoagulation. So how can you give anticoagulation safely to these patients? Well, that was a matter of debate, and especially in the 90s, a couple of studies were done. We did a Cochrane review on this topic already a few years ago. And we included only the studies that were of sufficient quality, which was a German study done by Einhaupel and a Dutch-English study done by my promoter, actually, in the end of the 90s. And if you look, only 79 patients were included in total. So these are both very, very small randomized trials, which is, of course, due to the rarity of the disease. And you can see, if you look at the main outcome, which is, in this case, death or dependency, you can see that the odds ratio, or the risk ratio, favors the use of anticoagulation with a risk ratio of 0.46, but with a very broad 95% confidence interval. So there's a lot of uncertainty about the efficacy of heparin treatment, but it's hard to get better evidence. And at the very least, the evidence that we have clearly suggests a beneficial effect of heparin in these patients. And what was very important is that what we didn't see in these trials, and what was, of course, the biggest fear, was there were no major bleeding complications. So none of the patients that received heparin developed a major bleeding complication, especially no intracranial bleeding, while there were actually 2 intracranial bleeds in the placebo arms, suggesting that the theory that you have to treat the thrombosis because it actually prevents bleeding was justified. So based on these data, we concluded that anticoagulant treatment appears to be safe and associated with a potentially important reduction in the risk of death or dependency, which did not reach statistical significance. So we formulated it quite carefully. And now all the guidelines recommend the use of heparin I'm not going to list all of them, but the major ones are the European Stroke Organization guideline, which is already, I guess, 5 years old, but not as old as the AHA guideline, which I would strongly recommend to my American colleagues to update because it's clearly outdated. But both of them recommend the use of anticoagulation. And I think pretty much all of us now use it. So if you're going to use heparin, then you need to decide which type of heparin you want to use. And you can choose unfractionated heparin, or you can choose low molecular weight heparin. And I'll be very interested to hear what you people in New York are using. So unfractionated heparin has a swift action, and it, of course, a downside is it requires dose adjustments. A plus side, also a downside, is it has a short half-life, and it can be reversed if necessary. The short half-life also makes that it's quite difficult to actually get it into the right range, and patients are often over or underdosed, so that's definitely a disadvantage. Low molecular weight heparin is body weight adjusted, so you don't require monitoring. One downside is that it cannot be completely reversed. You can partially reverse it, but not completely. So what does the evidence tell us of what to choose? And I would argue that low molecular weight heparin is the better choice based on what I'm going to present you here. First of all, there actually was a randomized trial done in CVT patients. It was done in India, published in the European Journal of Neurology, where patients were randomized between low molecular weight heparin and unfractionated heparin. And the patients randomized to low molecular weight heparin clearly had a much better outcome with a lower mortality. The quality of that trial was not as good, so that's why it was received with some skepticism, but at the very least, it does suggest that low molecular weight heparin is better. We did a non-randomized study a few years ago, which also clearly showed that low molecular weight heparin had a better safety profile. We know that in leg vein thrombosis, where many trials have been done to compare both low molecular weight to unfractionated heparin, clearly showed that low molecular weight heparin is superior, especially in the reduction of bleeding complications. So I tend to use low molecular weight heparin, except in very specific situations. So if I think that a patient requires surgery in the coming hours, then I'll use unfractionated heparin because it's easier to reverse. And patients that are admitted to the ICU, which in our case is only a minority of the patients, ICU docs still tend to give heparin. I haven't been able to convince them to switch to low molecular weight heparin. But other than that, I always start low molecular weight heparin. Interestingly, if you ask neurologists, and I've done this, but a lot of other people have done this since, is that still many, or I would say most neurologists internationally favor unfractionated heparin. So again, it'll be very interesting to hear what you guys do. Okay, so then I'm going to move to endovascular treatment. Endovascular treatment, it can be either done with thrombolysis, chemical thrombolysis, or thrombectomy. And the idea, of course, with endovascular treatment is that it can result in faster recanalization of the major sinuses. So you don't have to wait for the spontaneous recanalization under heparin treatment. You can get it done in a matter of hours. But does that offset the potential risk of bleeding or other complications? And until very recently, we had no evidence from randomized trials to guide us. So this is the reason that a few years back, we started the 2ACT trial, which is an abbreviation for what you can see here. And it was published in JAMA Neurology last year. And I just want to run you through it. So 2ACT was an investigator-initiated international randomized controlled trial. So we only had funding from the Dutch Heart Foundation, not from industry. We randomized severe cases with a high probability of poor outcome, and they were randomized between the standard treatment or standard treatment with endovascular treatment. Primary endpoint was the ranking scale at 12 months. And originally, we hoped to include 164 patients, but the trial was terminated after the first interim analysis because of futility, as I'll show you in a few minutes. So which patients did we include? Well, those with radiologically proven CVT, so either with CTV or MRV. And they had to have a severe CVT because we examined the ICVT data and found a couple of risk factors for poor prognosis. And we said, well, this patient needs to have a high risk of a poor outcome, defined as the presence of one of these, at least one of these risk factors. So coma, mental status disorder, intracerebral hemorrhage, or thrombosis of the deep venous system. And then in addition, there had to be uncertainty by the treating physician about what the optimal treatment was. So in the end, we randomized 67 patients, 33 to endovascular and 34 to standard treatment. We had outcome data for all patients, although there was one patient that was lost to follow-up for the 12 months outcome, but we had 6-month outcome in that patient. And you can see that the baseline characteristics were pretty well balanced. Of course, small groups, so there's bound to be some differences, but the age was around 40. Most were women, as you would expect. NHSS is 12, which is for an LVO stroke trial, of course, low, but for a CVT trial, it's quite high. A lot of patients had seizures, quite a few patients, around 15 to 24% were comatose, and 2/3 had an intracerebral hemorrhage. And the primary outcome, which is the reason why the DSMB recommended terminating the trial early, was pretty much 1 was the odds ratio, pretty close to 1. So there was absolutely no difference in primary outcome, which is a ranking scale of 0 or 1 between the two treatments. So this suggested that there was no beneficial effect of endovascular treatment in these patients. Which is not listed here, but there were also no major safety concerns. Definitely, there was no increased risk of symptomatic intracoronary hemorrhage in the endovascular treatment arm. We did see a couple of perforations in the endovascular treatment arm, in total in 3 patients, but in none of them it led to a symptomatic intracoronary hemorrhage because it actually happened at the beginning of the procedure when there was still thrombosis. So in most cases, the procedure was then terminated, not executed further. But it does show that this procedure is not completely without risk. Okay, so whenever a patient is clinically stable, I tend to switch to oral anticoagulation. We don't know how long we should treat these patients, but the guidelines, which is mostly copied from deep vein thrombosis of the leg, say that for a provoked case, we treat 3 to 6 months, and for unprovoked cases, 6 to 12 months. And of course, if a patient has a recurrent thrombosis or severe thrombophilia or an antiphospholipid syndrome, then we treat for indefinitely. Vitamin K antagonists are routinely used and also in the guidelines, but there was a recent trial on the use of DOACs in CVT, which I'll briefly discuss, and which I think has now led to an increased use of DOACs in these patients. Again, that'll be interesting to hear what you guys use. So this was a trial that was led by José Ferro, which is a colleague from Portugal with whom I collaborate very often. I was also on the steering committee, and this was published in 2019. Also in the JAMA Neurology. It's called the RESPECT CVT trial. This was an exploratory randomized controlled trial. So this trial was sponsored by Boehringer, and patients were randomized between dabigatran or INR adjusted warfarin. So we included patients that were initially treated with heparin for 5 to 15 days and then were clinically stable. They were then randomized. So there's no data on the use of DOACs in the hyperacute phase. So all patients receive heparin for at least 5 days. We used a primary endpoint, a composite of recurrent VT or major bleeding at 24 weeks. And the sample size was put at 120 patients. Again, it was an exploratory trial, so there was no formal sample size calculation done because we already knew that that would not be reasonable. If we would have done a reasonable sample size calculation, thousands of patients would have been necessary, and that was never going to happen. So again, it was exploratory to get at least some high quality data, randomized data on the efficacy and safety of DOACs. So 120 patients were randomized, 60 to dabigatran and 60 to warfarin, and we had outcome data in all patients. And you can see a little bit about the baseline characteristics. Again, most of these are young patients under 50, slightly more than half of them were women. And we had also patients with an intracerebral hemorrhage. That was in total 1/3 of patients, which of course important. And there were some patients who had a decreased consciousness, but that was not as common because, of course, those patients are often not clinically stable within 2 weeks, so they could not be randomized. And here you can see the primary endpoint. There was 1 major bleeding in the dabigatran group, so there were no recurrent thrombosis in any of the groups to start there. No recurrent thrombosis, that did not occur. But there were in total 3 major bleeds, 1 in the dabigatran group, which was an intestinal bleed, and 2 in the warfarin group. So if you calculate that back to percentages, it's 1.7 compared to 3.3. But again, we didn't do any statistics on this because we already knew that that would be nonsense, basically, because the numbers are so small. But we do give 95% confidence intervals, which are, of course, wide. And then I just want to briefly highlight the study that we're doing right now, which is called the DOAC CVT study, which is run by me, José Ferro from Lisbon, Jukka Putala from Finland, and Turgut Tadlisimak from Sweden. And Katie Krzewicka, who's from Poland, is a PhD student with me. She coordinates the study. And we also have an American national leader, Waneo Okam, from Duke University. And it's an international study on, it's a phase 4 registry study on the safety and efficacy of DOACs and CVT. So it's an observational study, and we try to recruit data of 500 patients internationally, both with DOACs and warfarin or any other vitamin K antagonist, so that we get some real world data on the safety and efficacy of DOACs in these patients. So we've recruited so far up, I think 170 patients. We're actually ahead of recruitment. But very recently, the US joined when AOCOM included its first 2 patients. So if you're interested in this study, you can either contact me, look it up at our website, cerebralvenoustrombosis.com, and then you can go to the professionals and find the study, or contact one AOCOM, and we can see if we can let you guys join the study, which of course would be very helpful. Okay, so I used to call this take-home messages, but someone told me that I should call it take-home, but take-to-work messages, which I guess is a better term. So this is like the interim part of the talk, because now we're going to switch to VITT, but I thought it would be good to end this part with the take-to-work messages on CVT in general. And these are the 5 ones I wanted to tell you. 1, CVT remains an uncommon disease, but the incidence is increasing. 2, the prognosis of CVT has improved, but many patients suffer from residual symptoms, which often has a negative effect on their quality of life. 3, I would recommend to treat patients with CVT in the acute phase with heparin, and my recommendation would be to use low molecular weight heparin. But if you're a believer in unfractionated heparin, I can accept that as well, but I do try to convince as many people as possible to use low molecular weight heparin. Based on the 2-act trial, my conclusion is that endovascular treatment should not be routinely used to treat CVT, which doesn't mean that you should never use it, but I don't think there's any evidence to routinely use it. We use it very rarely in specific circumstances. Maybe we can discuss it later, but again, do not use it routinely. And finally, in RESPECT CVT, the risk of recurrent thrombosis and major bleeding were low for both dabigatran and warfarin, which of course we don't have certainty about whether we can use DOACs, but I think they're increasingly being used, and hopefully we can include as many patients as possible in DOAC CVT to get a better idea on the real world safety and efficacy of DOACs in these patients. Okay, so now we're going to switch to cerebral venous thrombosis after COVID-19 vaccination, which is something that was all over the news, I guess about a year ago now it started. First with news outlets. So it was in the New York Times, it was on CNN, it was everywhere. The EMA, the European Medicines Agency, and also the FDA were all over it. And then very soon, these papers in the New England Journal of Medicine and a little later in the JAMA came out, which all reported patients with a condition that was later termed vaccine-induced immune thrombotic thrombocytopenia, or VITT, after COVID-19 vaccination. And that's something we went into as well, so I'll discuss that briefly. So the epidemiology of VITT is it occurs within a month and not immediately. Generally, we say after 4 days, so between 4 and 28 days, after vaccination with either one of these adenovirus-based vaccines. So the AstraZeneca vaccine, which is called officially the ChAdOx1 nCoV-19, which you don't have in the US because it's not approved in the US. AstraZeneca never applied for approval. My guess is because they knew they were never going to get it after the appearance of VITT cases. And the other vaccine which is used in the US is the Johnson & Johnson vaccine. So those are the 2 adenoviral based vaccines for which we definitely know that VITT occurs. The incidence appears to vary, which is still interesting and quite puzzling to me. So for the Johnson & Johnson vaccine, it's around 1 in 400,000, while for the AstraZeneca vaccine, it's much higher. It's between 1 in 40,000 to 1 in 130,000. So quite a few studies were done on this. We published a study in Neurology a few months ago that also found this an incidence within this range. It may be higher in younger women, and very interesting, it may vary per country. And this is something maybe we can get back to in the discussion, especially in the non-Western countries. As far as I know right now, is that the incidence appears to be much lower, which is something we haven't completely explained yet, but it's definitely interesting. So the clinical manifestations are a combination of thrombosis with severe thrombocytopenia. That's basically what if you see that combination, you should check, did this patient receive any COVID-19 vaccine quite recently, because that's the giveaway. So before we go further, I want to stress this issue because I often get get asked this question: does VITT occur after mRNA vaccines? And for that, I always use the FDA data because I think they have the best information. And this is already a little bit outdated, but nothing has changed. Back a few months ago, or actually almost a year ago, when the FDA looked at this in their VAERS system, they already had 250 million vaccinations with the 2 mRNA vaccines, and there were no report cases. It was called here TTS, but now we call it VITT. And as far as I know, and I look at these publications quite often, nothing has changed. So there's absolutely no risk of VITT after an mRNA vaccine. So the pathophysiology is something that especially Dr. Greinacher, but also he's from Germany, but also the group from Scully, she's a hematologist from the UK, they uncovered quite quickly. They're both hematologists who already specialized in what we call HIT, heparin-induced thrombocytopenia. And for them, it was quite easy to figure this out because the syndrome resembles that of HIT, at least hematologically. So what you get is you get antibodies against platelet factor 4, and those antibodies against platelet factor 4 lead to, in this case, an heparin-independent platelet activation. So normally in HIT, when you treat a patient, especially with unfractionated heparin, there's a risk that the heparin induces the formation of these PF4 antibodies, and that together leads to thrombosis and severe thrombocytopenia because you get clustering of those and activation of those thrombocytes due to those antibodies. But it was already known that not only heparin can induce that, also there's an autoimmune variant, for instance, in response to some kind of infection. And it appears that the VITT that these patients are having is a very similar mechanism. So it's an heparin-independent development of PF4 antibodies, but then you get the same condition as you can see in HIT, and you get these PF4 antibodies. So the group from the UK suggested these criteria for the diagnosis of VITT, which are, I think they're good. I don't think they're excellent. There's something to be said about it, but they work quite well in daily use. So you need to have symptom onset between 5 and 30 days. 4 and 28, whatever, it's within that range after either AstraZeneca or Johnson & Johnson vaccine. Then you need to have thrombosis, thrombocytopenia below 150. Increased D-dimer is very typical, and especially it's very high, above 4,000. And then the PF4 antibodies with either an ELISA or a functional assay, and don't use the rapid test because it's often false negative. Now, if you have all 5 criteria, you have a definite fit. With 4, it's a probable fit, and with 3, it's called a possible fit. So whenever you have a case, the treatment is pretty straightforward. Most important thing is do not wait for the PF4 antibody result if VITT is likely, because it can take a number of days. So if you have a likely VITT, a probable VITT, use immunomodulation, especially IVIG. As neurologists, we often use, of course, in neuromuscular disorders like Guillain-Barré syndrome. So we know this quite well. You give 0.5 to 1 gram per kilogram daily for 2 days. So mostly we will give 1 gram per kilogram per day for 2 days. And another alternative is to give plasma exchange, which is not done as often, but it's definitely something to consider. You should give anticoagulation, but probably not a heparin, because we don't actually know this for sure, but there's a chance that heparin, because it's associated with HIT, may increase the formation of PF4 antibodies. So we prefer a non-heparin anticoagulant like fondaparinux. A DOAC could be, but mostly it's fondaparinux or a gatroband that's used. Even though these patients have a thrombocytopenia, you should probably avoid platelet transfusions because, again, you give more platelets, which can increase the platelet aggregation and give actually more problems. So try to avoid these platelet transfusions. And you should consult an expert on VITT, which in most hospitals will be a hematologist. So a lot of these patients will come under the care of neurologists, but it should be a multidisciplinary approach. And of course, because it's a side effect of a vaccine, you should notify the regulatory authorities. So why did we get into this? Very simple, because and that was clear from the beginning, most of these patients, for some reason, have a thrombosis in the brain. They get CVT. So it's not just a thrombosis, it's a cerebral venous thrombosis. And why we still don't know. Why there's a predilection to develop thrombosis in the brain is completely unknown, but it's very clear from all the data that this is the case. So what we did is within our group of the International Cerebral Venous Thrombosis Consortium, which is a group of international researchers that I'm in the leadership of, we jumped on this and we said we have to examine this. And this is the group that collaborates. So some of these faces you recognize from the DOAC CVT study, but it's quite an international group from a lot of countries that all collaborate on CVT in general, and now started collaborating on looking at VITT. And the first question we had, and that was a year ago, and the first question we had is, when we read about those poor PF4 antibodies and the thrombocytopenia, nobody knew for sure that this was actually a side effect of the vaccine. So the first question was, well, how often does this actually occur normally in CVT? So without the COVID-19, so before the COVID-19 pandemic, was this really as rare? And that's something that we examined, and we published that in the JAMA last year. So we had a big group of patients, of course, because we've been working on this disease for a long time. So we had almost 1,000 patients, of which we could include 825 patients. And they were all from before the COVID-19 pandemic. And then we looked, so how often do these patients have thrombocytopenia? So it was present in around 8% of these patients. So it was uncommon, but not extremely rare. But then if we looked further, like how many of these patients had a hit, which is what we're seeing in these VITT patients, there was only one patient. So 1 in 1,000 patients in our group had a classic hit. And then we had plasma of around 10% of these patients stored in the freezer. And we took it out and we tested them for PF4 antibodies, and not a single patient came back positive for PF4 antibodies. So what this told us is that before the whole COVID-19 pandemic, this clinical picture of CVT with thrombocytopenia and PF4 antibodies was extremely rare. So it wasn't something that we knew, which was our gut feeling at the beginning, because none of us recognized it. But again, nobody had researched it. So this study showed that even though it wasn't direct evidence, there was indirect evidence suggesting that what we were seeing had to be related somehow to the vaccine, and because it's not something that we were seeing commonly before. The second question is, so now that we have this VITT-associated CVT, what are the clinical manifestations and the prognosis of these patients? And that was another study. It was sponsored by the ESO and the EAN, which is the European Academy of Neurology, and the European Stroke Organization. And this study we published in the JAMA Neurology a little later than the other study. And it was an international registry where we included adult patients with CVT within 28 days after any SARS-CoV-2 vaccination. So we didn't limit to the adenovirus vaccines because we wanted to look broad, and at the time we weren't completely sure which vaccine could give this. So all vaccines were eligible. And in the end, we got data from hospitals out of 19 countries. And the first report was written with using data until mid-June 2021. And it was published later that year in JAMA Neurology. So we had in total 123 patients submitted. A couple of had to be included. So 116 patients included, of whom 2/3 had a VITT and 1/3 did not have a VITT. So what that told us is that the VITT cases, which were pretty much all AstraZeneca, although there was one Janssen and actually one Pfizer, which I don't think had a true VITT, but still met the qualifications. And then the no VITT cases, they were probably just coincidental. So most of these just did not have a thrombocytopenia. They were just probably vaccinated and then developed a CVT by chance within a month. And then we compared it to a control group of 200 patients that had CVT prior to the COVID-19 pandemic. So this is a small group between 2015 and 2017 that we could use as a comparison of how we know CVT normally behaves. So here are the baseline characteristics. Again, in the left is the 78 VITT cases, and then the no VITT cases, which are probably coincidental, and then the 200 pre-COVID-19 CVT controls. You can see most patients were between the age of 40 and 50, majority were women. That was in all three groups the same. At the time, it was thought that maybe VITT was caused by a COVID-19 infection in combination with the vaccine, but our data did not suggest that. COVID-19 infection was very rare among the VITT cases, the reason COVID-19 infection. Most of these patients developed CVT within the first 1 or 2 weeks after vaccination. But where they start to differ the groups is the severity of the condition. So you can see in the VITT cases, they were in a much more severe condition with 1/4 of patients comatose at admission, while that was very rare in the no VITT cases, and also in the pre-COVID-19 CVT controls, where we know that only 5% is comatose. And also intracerebral hemorrhage was much more common in the VITT cases, 2/3 of patients. You can see here that the baseline platelet count was usually between 25 and 75. So most patients had either severe or a moderate thrombocytopenia. And in those where PF4 antibodies were tested, which was not done in all cases, but in most of them, in the VITT cases, they were present in 91% of those tested. And where it became really interesting, but also worrisome in a way, is looking at the complications and the outcome. So first of all, we saw that in the VITT cases, 1/3 of all these patients had a concomitant thromboembolism. So that in addition to the CVT, they had another thrombosis. So that means that, while that's very rare in the normal CVT group. So what that teaches us is that when you have a case of VITT, you should be in the lookout of other locations of thrombosis. So if they're if shortness of breath, look for pulmonary embolism. If they have a pain in their belly, check for mesenteric thrombosis and things like that. So be on the lookout for other locations of thrombosis. Major bleeding was slightly more common, but I don't think we're completely sure whether that's a true effect, although it was about 3 times as high as in the normal control CVT group. But of course, the most apparent finding was the mortality. So normally, like I said, mortality of CVT is acute mortality is low. In our series, it was 4%. In the no VITT case, it was 5%, very similar. But then if you look at the VITT cases, almost half of these patients died during hospitalization, which is of course much, much higher. Okay, so then I'm nearing the completion of the talk. And the last question that we had at the time, we're still working on a couple of other things, but one of the questions we had, well, is the mortality of CVT VITT decreasing? And the reason that we thought that is that in the beginning, we didn't know what it was and we didn't know how to treat it. And now we have all these treatment recommendations. So we were hoping that mortality had gone down. So what we did is we looked at the data from the European Medicines Agency, and we looked at whether we could find a temporal trend. So we looked at cases that were diagnosed before the 28th of March, which was when the first New England paper was published, compared to those diagnosed after 28th of March. And what we saw is that there was an absolute decrease in mortality of 25% in the later patients. So even though that, of course, we cannot conclude that this is due to better diagnosis or better treatment, because there could be all kinds of biases, the drop is quite considerably, right? It almost decreased to half of the early mortality. And at the very least, it suggests that that may be due to faster diagnosis, faster recognition, and improved treatment. So that's a slightly positive note. So if you want to read more on this topic, specifically on VITT, we have quite a few papers published. Most of them already, I already touched base on, and we're still working on a couple of other papers on the same topic. So that brings me to the take to work messages regarding VITT. I would say that CVT in combination with severe thrombocytopenia and the PF4 antibodies was very uncommon prior to the COVID-19 pandemic, again, with which indirect evidence that what we were seeing with the VITT cases was really due to the vaccines. VITT is a rare but a severe side effect of the AstraZeneca and Johnson & Johnson vaccines with a high mortality, which hopefully is decreasing. And VITT requires a specific diagnostic workup, the PF4 ELISA, and treatment, which is based on immunomodulation, non-heparin anticoagulants, and avoiding platelet transfusion. Of course, there's many people that I've collaborated with. Like I said, it's a true international collaboration. So there's a very big group, and this is only a small group of them, which I guess is the core group of the CVT consortium. But there's many others collaborating authors from the CVT consortium. If you want to discuss more, I can answer questions now, but you can also always email me at this email address if you want more information. Thanks.
Thank you, Dr. Coutinho. That was a really amazing presentation. So now we open the microphone for the questions. Is one in the audience want to ask? Also, you can write questions in the chat. Some people prefer that.
Yeah, hi, this is Dr. Paramitsakis. Dr. Coutinho, thank you very much. That was an excellent overview. And thank you very much for the research that you do on those. Can you please remind us whether you use any warfarin or Coumadin for the 3 or 6 months of the period that you treat these patients after the acute phase, or you just switch to DOACs at this point, Eliquis that apixaban, for example, that we use here.
Yeah. So the patients that I treat, I generally switch to DOACs. I think based on what we know, I think the evidence suggests that it's probably comparable, which is also based on data from other conditions like other forms of thrombosis. So I tend to switch to DOACs now, also because it's, of course, much more user-friendly for the patients. But I don't think there's nothing wrong with VKA. You can use definitely VKA as well. I mean, there's certainly no evidence to suggest that DOACs are superior to VKA. I think they're probably equivalent and a little easier to use. So most patients, when I discuss it, tend to favor the use of DOACs if I tell them that what I just told you. And I think in the country, what we're seeing is it's more or less the same. I would say in the Netherlands, most now use DOACs. It's probably around 2-to-1 ratio. But internationally, it varies quite a bit still.
Thank you very much. I hope it comes in the upcoming AHA guidelines.
Are they working on that? I don't know, actually.
Yeah, I'm not sure, but as you said, it's several years, so it needs an update.
Hi, Dr. Coutinho. This is Dr. Tony Wang. I'm a neurointerventionist. I have two questions. One is related to the endovascular treatment for CVT. Could you further elaborate on the criteria when you decide clinically when to intervene endovascularly? And would this patient selection difference make a difference in the potential outcomes?
Yeah, I always find that a difficult subject. I think with the TUAC, what we show is that merely selection based on a poor prognosis, that's probably not the right way to go, right? Because there's no evidence that suggests superiority. I think we don't have the tools yet available to really select who benefits. So if you look at it from an ischemic stroke perspective, right, in the beginning, we also, those trials that were published in 2012, where there was no real selection, they were also failed.
Exactly.
Yeah, so I guess what we don't have the radiological tools yet. At least we don't know how to interpret them yet. So I think a lot of groups are working now. I know the Portuguese group is working on perfusion MRI to see if that somehow can suggest who may benefit of endovascular treatment. But as far as I know, nobody has any established criteria. I know Mayan Goyal from Calgary is also working on this. So hopefully in a few years, we know with radiological techniques if they can help us with the selection. Until that time, the group of patients that I tend to select for endovascular treatment, and again, it's quite rare, but the ones that we tend to treat are, for instance, patients with a threatened vision, because we do believe that if we can open up the sinuses quickly, patients with a threatened vision and papilledema, we can reverse it. So we have some good, but not all of them, but some good experience with that. And the other group is sometimes the patients that have like a decreased consciousness due to severe intracranial hypertension. So they don't have any mass effect. They don't have any large parenchymal lesions. They just have an outflow problem, which is very rare, but I've seen it a handful of times. Those are also the groups that we sometimes treat with endovascular treatment. But I think we do it now maybe twice a year.
Right. So I think just deriving from the experience we have as acute ischemic stroke LVOs, not only the clinical or imaging criteria are important, but also timing for treatment also, significantly can affect your outcome as well. When to decide to treat this patient and how fast you treat them, right? So I think we learned from the ischemic stroke from the 3 failed trials in 2013 that MR rescue especially. I think that's what we know. I think I'm looking forward to for the definition of these population that potentially can benefit from something that beyond just the anticoagulation.
Yeah, yeah, me too.
My other question is that to what extent do you think the superiority of the low molecular weight heparin to the alpha-fraction heparin is because of the challenge or difficulties of achieving therapeutic levels for the alpha-fraction, as opposed to mechanistically or molecularly that's superior?
So there was a slight hiccup,
Just like
but I think the question was if it's due
yeah, I'm sorry.
to.
Can I,
Oh, I think your question was: is it related to the over or underdosing that we get with unfractionated heparin, right? Yeah, I think that is the case.
yes.
I mean, we know, and there's quite a few studies that have looked at this, that under or overdosing for any indication for unfractionated heparin is common, even in ICUs. It's difficult to get patients between those target APTTs. And obviously, underdosing increases the risk of thrombosis, and overdosing increases the risk of hemorrhage. So yeah, I think that's very likely. And I don't know what you guys use. Do you use low molecular weight heparin or unfractionated heparin?
I think just like I said, we neurologists oftentimes are following our habits, tend to be, whatever we used to use, we continue to use them. We typically use, at least in my case, unfractionated heparin. And for these cases, actually, I don't know if you guys give them bolus doses before the maintenance dose, but we typically use them, at least in my practice. And for those patients who are difficult to have blood draws and you can check their PTT IERs frequently, then we use them with the low molecular weight heparins.
I would say switch to low molecular weight heparin. It's much easier, saves the residents a lot of time, and I think it's better for the patients. It's really my belief.
Good to know.
And I think that's what the data suggests also.
If you want to use the low, fractional heparin for say pre-op cases, as you mentioned, would you give the bolus dose or just the maintenance dose with the PTT high? Okay.
No, normally we would give a bolus.
Okay. Thank you. Amazing work. Keep us posted.
Thanks.
Yes, you've been discussing acute cerebral vein thrombosis, essentially, which presents as a fairly acute syndrome, and the patient is worked up and the diagnosis is made. What about patients who've had prolonged CVT and have presented with vague things like headache rather than the typical focal symptoms? Mm-hmm. They immediately draw you to the diagnosis. Somebody with headache had a headache for a couple of months. Should we include MRVs in the workup of headaches as well as MRIs?
I mean, it's a difficult one. Obviously, if you do that routinely, you'll catch a couple of CVTs a year, but it's still going to be a very rare disease. So the absolute majority of your patients will not have a CVT. So I would do it under certain situations. So if, for instance, a patient has high risk factors, if it's a young woman on oral contraceptives, especially if they're obese, I would say there's a risk, or if they have a history of thrombosis, or if they have papilledema. I mean, obviously, if they have clear signs of intracranial hypertension, then I would do it. But just a patient with headache without anything else, no, I don't think we should do routine MRVs. I don't think that's cost effective.
What about migraine in women on oral contraceptives? Should we do MRVs on them? Patient has migraine. She starts taking oral contraceptives. Not. And she has no symptoms.
No. Just if it's in real migraine, intermittent headaches, no, I would not do an MRV.
Yeah. Or an increase in headaches, an increase in frequency, going from episodic to chronic.
I wouldn't do that. As long as it's intermittent, I don't think it can be caused by CVT.
Okay. Thank you.
Dr. Coutinho, let me ask, Dr. Litton wanted to ask some questions, but I don't see him in the chat. Dr. Litton, are you there? I think we lost him. There is one question from the chat, Dr. Coutinho. It's from one of our residents, the chief resident, Miguel Rosa. How long do you recommend anticoagulation after CVT?
Yeah, so most of the times I would treat for 6 months, unless there's a clear provoked CVT. So if it's an infection-related CVT, then we can do a little shorter, like 3 to 6 months. Although most patients, I end up treating 6 months. So sometimes the patient is very reluctant to stop anticoagulation, in which case sometimes I prolong it to go like 12 months. And of course, if a patient has a recurrent thrombosis or very high recurrence risk with like an antiphospholipid syndrome, then I treat indefinitely.
And there is another question from the chat: is what defines the time frame for acute phase treatment?
So what is meant here, like how long is the time phase, or like when do you still consider a patient when they come in to be treated acutely?
I think that's going to be when they consider the patient should be treated acutely.
Okay, so I mean, if you have a patient with a very chronic onset, like a long-term headaches for weeks or months, and no focal symptoms, no parenchymal lesions. So if you think that the CVT developed weeks or months ago and the patient comes in, I think you can immediately go to oral anticoagulation. I don't think you have to give any heparin at that time anymore. But that's a small group of patients. In my experience, most of them come in with shorter duration of headache, maybe 1-2 weeks maximum, often shorter, and then focal symptoms. And in those cases, I always start with heparin, because I think that's what the evidence suggests, that at least for 5 days, you should treat with heparin at least, and then you can consider switching. And that's in the ones that are really clinically stable. I mean, often you see like with seizures or other issues that it takes a couple of days for them to become stable. And there's really no rush to start oral anticoagulation in these patients, right? I mean, you know, with heparin that you're treating them in a good way. And these patients are hospitalized for quite a long time anyway, right? So it doesn't hinder them as much. So in those cases, I don't think there's any rush switching to oral anticoagulation.
Yes, this was my question. This is Dr. Yusbashian from VA. I was actually asking, how long do you consider to treat in acute phase? At least how many days?
Yeah, so I would say at least 5 days.
5 days. Thank you.
But if it's a very severe case, I mean, I've had them in the hospital for weeks and treat them for like 3 to 4 weeks with heparin.
Thank you.
I have a question. This is Sanskriti Mishra, one of the stroke neurologists. Just kind of going on to that, 2 questions. First was, if a patient does have, say, persistent chronic kind of venous thrombosis 6 months later, do you continue their anticoagulation at that point? Or because at this point it's chronic stage, you would stop it and maybe switch them to an antiplatelet? That's the first question I have.
Well, I never switch to antiplatelets, although I know that it is done sometimes. I never do that. Sometimes when there's still clear thrombosis present, we treat a little longer, closer to 12 months. But for me, I don't think that the question that hasn't been answered, in my opinion, is if the presence of chronic thrombosis, I think most likely does not predict a risk of new thrombosis in these patients. So I don't think continuing anticoagulation at that point helps solve that chronic thrombosis or reduce the risk of recurrent thrombosis. But again, I don't think enough studies have been done on that topic. But as long as that evidence is not there, I do tend to stop anticoagulation, even if there's a persistent thrombosis, because I think it's very unlikely that the thrombosis is still active. That's also how I explain it to patients, because they're always very worried about that there's still something present. So I always tell them in the beginning, it's never going to go away completely, right? If you look carefully, you always see some residual thrombosis in these patients. And I always explain to them, it's not a thrombus anymore. It's like, it's hardened, it's there, it's going to stay there forever. It's never going to go anyway. It's never going to go away. So I say that for them not to worry as much about that there's still some residual changes in that sinus.
Okay, thank you. That makes sense. That's the same pretty much, I think, what we do as well. The other question was about using the DOACs. I know you mentioned that at least where you are, like your standard practice use DOACs. I don't know. I don't think most of us use it as far as I know in our practice. And looking at the literature, I mean, my understanding was there's not enough literature to say that DOAC, especially the dabigatran, is non-inferior at this time for warfarin. I mean, it was an exploratory study with, I think, 120 patients. So I was just wondering, like, based on your experience, have you seen the outcomes are better with the DOACs? And is there any, I know there's a trial going on right now, but just wondering what convinced you guys to switch to DOACs?
I mean, I can't give you a scientific argument against what you just said. I think clearly it hasn't been shown that DOACs are non-inferior, right?
Yeah.
The problem with CVT is that evidence, I don't think, is ever going to come, right? It's too rare a disease to get that level of certainty. So if you do research on CVT, I'm quite used to using inferior data and then making decisions on what to do. Because it's the same with heparin in general, and it's the same with using VKA for that matter, or endovascular treatment, or any other intervention that we do in these patients. Again, I don't think there's anything wrong with VKA. So if you say, look, I don't want to, I'm not convinced enough to use DOACs, again, there's nothing wrong with that at all. I can't tell you out of my own experience what the effect of DOACs is, because I mean, we see quite a few patients, but I don't think we see enough for me to get a clear picture, at least not better than what we see in the trial. I do hope that DOAC CVT will provide some guidance. Again, it's an observational study, so it'll be a biased comparison, but by getting large enough number of patients, I hope that we can at least say something about risk of bleeding.
All right, thanks. Next slide.
Okay, got it. Yeah, I agree. There's really, and these trials we don't expect them to have thousands of patients, like you said. All right, so hopefully we also in North America end up switching to DOACs. Thank you for your talk. That was great.
My pleasure.
I think we have space for one more question. Is there anyone else with a question? I think there are no more questions. I just want to thank Dr. Coutinho for your time, for offering this very great lecture, and I hope we can see you in New York. I think you're planning to visit us, so maybe someone else can see you and talk to you about a little bit more about research and do some collaboration. Thank you again.
Thank you.
Okay, had a great day, everyone. And today is a match day, so I think it's a very important day for us in the United States. We had a new residence next year.
Yeah. Thank you so much. Take care.